You are listening to the Wealth Formula Podcast with Buck Joffrey. Get ready to change your life.
Welcome, everybody. This is Buck Joffrey with the Wealth Formula Podcast, coming to you from Santa Barbara, California, in captivity as everyone else. Before I get started, I want to remind you that there is a website called wealthformula.com that you should visit if you'd like to get some of the resources available there for free, because the podcast is really only part of the fun. There's also a course called Your Roadmap to Real Wealth, which you can potentially get involved with and become part of the Wealth Formula Network community. You can go to, you can find that at wealthformula.com or also directly at wealthformularoadmap.com. I also would like to suggest that you strongly consider joining that during this time off, because it's a good time, if you've got a little extra time to actually buttress your financial knowledge now and get involved with this community. We do these bi-weekly Zoom calls, they're video calls, and we have this Facebook groups, and we have lots of really good discussions going on there. Again, check that out. If you go to wealthformularoadmap.com, you can do that. Now, as for today, actually, the podcast, this is one of two. It ran long, and I thought it'd be good to cut them up into two. And we're releasing them at the same time, but it'll be easier to digest for your commutes or whatever. But, the thing is, we live in a very, very strange time in that even public health issues are being politicized. There are wingnuts on the right, right? And there's wingnuts on the left. The wingnuts on the right want to downplay a virus that has already taken the lives of more people than died in the Vietnam War. The wingnuts on the left want to demonize anyone who even suggests an alternative approach to dealing with the pandemic outside of staying home in perpetuity. They want us just to completely ignore the pain, suffering, death that comes not from necessarily from the virus, but from poverty and from a financial depression, which is very, very well documented. All you have to go back is and look at the 30s to see how that turns out. So the polarity of thought during this Black Swan event, unfortunately is the product of politicized news on both sides. And that's a problem for us all, unfortunately. And as a physician, and really what I consider at least an overall rational guy who doesn't get caught up in, the tribalism of, modern day politics, this kind of partisanship, is downright maddening. And that said, it's not surprising, right, from where we've actually come to, the point that we've come to. The funny thing is, and I don't know about you, but here's the thing is, like, when I was a kid, I'm 46 years old, and I was a kid, even down through before the internet came up, it seemed like there was really only one set of facts, right? And then you could base an opinion on them. You could base an opinion, and you could have rational, disagreements about them. But the problem now is that there is this idea that there are alternative facts, and that has made the world a very, very confusing place to navigate. That said, the idea that there are alternative sets of facts in science, in fact, is what they call these days fake news. You see, in science, we follow the studies. Sometimes the studies, they'll show disparity, and there may be a reason for that. But over time, if we do the studies rigorously, we do get to the bottom of things. But, this example of politicization of science and studies, all you have to do is look at this whole issue with hydrochloroquine. So Donald Trump has been talking it up, I think, to a certain inappropriately for a non-medical professional, like it's, a vitamin with no downside. And of course, that's not true. There's some potentially severe side effects of the drug that have actually killed people in the past few weeks. And on the other hand, in order to prove Trump wrong at every turn, the liberal news media makes hydrochloroquine sound like an asinine treatment in any shape, way, or form for COVID-19, which the evidence might actually suggest otherwise. What the evidence does suggest is that there might be a role for hydrochloroquine in the treatment of this illness, but it may be nuanced. It may be at certain phases of the disease, and it may not be helpful. It could make it worse at different phases in the disease. So bottom line is that there is a polarity, a politicization, a right or wrong, black or white on an issue that is inherently nuanced. And that's the problem, is that most things in life are nuanced. Now, this is just one example of complex issues that are being dealt with in sort of these ridiculous soundbite ways in the press. It's not helpful for anyone who really wants to understand what's really going on out there. So I took it upon myself to try to get together a podcast interview with people who actually know what they're talking about. So I've asked 3 guys to come on the show this week who happen to be fellow physicians like me, and they're also investors, and they have a lot of money in these markets, and they've had time to think about it. This week, we're going to focus on the disease itself mostly. So when we come back, you're going to hear our thoughts on what this whole COVID-19 thing is, and why it's as bad as it is, or if it's not as bad as we think it is. Some of the potential treatments out there, realities versus fiction. You're not going to want to miss this, so hang on. We'll be right back. Welcome back to the show, everyone. Today on Wealth Formula Podcast, this is a very interesting, different sort of format we got here. And, I think you'll find this useful. I have with me today, I have 3 of our listeners who also happen to be members of Wealth Formula Network, and they're also active members in Investor Club. And they're, like I said, they're physicians, all of them. And so we've got Ian Kurth, who's been on before. Ian is a neuroradiologist in Wisconsin. And we have Presh Mehta, who's a GI, gastroenterologist doctor in San Antonio. And then John Foley, who's a neurologist who has a lot of experience actually in immunology and things like that too. And he's based in Utah. Guys, first of all, I want to thank you for joining us.
Thanks for having us, Buck.
I want to just start out real quick, and just for a little perspective. This is kind of for each one of you, maybe just getting to know kind of like, what's your specialty? We already talked about that, but maybe kind of like, what's going on with your work right now, how you're handling it, and then, also, talk about what you do outside of medicine in terms of, your investments and stuff like that. Just a high level perspective so people know who's actually talking. Why don't we start with you, John?
Sure. So Buck, I'm a practicing neurologist specializing in clinical neuroimmunology, which primarily involves taking care of patients with multiple sclerosis and related disorders. I've had a significant interest, particularly in the coronavirus pandemic, due to the fact we have a lot of immunocompromised patients, primarily because of the medications that we're using in multiple sclerosis. So I've been following it pretty closely. Our practice right now is following the guidelines of the state of Utah. So we are primarily doing telemedicine for follow-up patients. We still do some infusions and emergent cases where we'll see the patients directly. As far as investments go, I'm not real big on the general stock market. I have a lot of investments in real estate and some backup investments in precious metals in case the world falls apart, which it's proceeding to do. So
I thought I saw some zombies in the backyard. And they came for me first because I was the one making fun of them.
Yeah.
Presh, how about you?
Yeah, thanks, Buck. My name is Paresh Mehta. I'm a practicing gastroenterologist down in San Antonio, Texas. There's about 25 of us in the group, and what does a gastroenterologist do? Well, we deal with all types of things such as acid reflux, ulcers, Crohn's disease, colon cancer prevention, and lots of other things in between. We also recently joined one of the largest groups in the country with now a total of 350 GI docs. That's sort of allowed us to grow and take into account some of the changes in medicine in regards to payers and other hospital systems. Our group currently, we're made up of surgical centers and outpatient office visits. Just like Utah and other states, most of our visits now have been sort of pushed to telehealth, which is a video platform to kind of chat like this online in order to diagnose and get things done for patients. Our surgical centers have been closed over the last 4 weeks, which means all of the procedures such as endoscopies, which are cameras going down, and colonoscopies have been shut down. But just recently, the governor of Texas is going to allow us to open back up. So we're slowly trying to figure out how to do that.
Got it. And you're also a guy who's, certainly got exposure to, multiple real estate offerings. And I know you do a lot of other things. And Ian, you've been on before, but if you want to give us a brief reintroduction to Ian Kurth, that'd be great.
Sure, thank you. So yeah, I gave my earlier introduction, but basically I'm a married father of four. I did my academic training at a variety of institutions, including undergrad at University of Michigan, medical school, Michigan State, and I did a diagnostic radiology residency and neuroradiology fellowship at Duke. For the past 13 years, I've been in private practice with the same group here in northern Wisconsin. And recently, because of the current circumstances, I've dusted off my old clinical reference books and have been forcing myself to explore some more clinical topics in an effort to remain informed and an effort to sort of be a resource to family and friends and community and so forth. So anything I say during this should be, listened to through the lens that I'm a radiologist.
Yeah. Well, but, listen, and Ian, if you go back and the shows previously, you get the whole story in Ian. It's really interesting. In many ways, I've called him the wealth formula poster child because of he's, your quintessential high paid professional who's really created, this very elaborate investing. I guess it's you would call it an investing business, right? I mean, he is looking at deals all the time and investing and deploying capital and thinking about this stuff. So I would encourage you to listen to that as well. Guys, obviously, the last, I'll just remind everybody that I actually am a physician, although I haven't practiced now for about 4 years. So this is for physicians who are going to talk about the current situation. And the reason I wanted to do this is because, frankly, there's so much BS out there. There's a lot of information about this virus, we call COVID-19. There's a lot of information on potential therapies, vaccines. Unfortunately, we live in a world where there are often more than one set of facts, which makes it really, really difficult for people to understand what the truth or what, what's not true. So, John, let's start with you. Right now, what is going on with the COVID-19 pandemic? And maybe you can kind of give us a little bit of an idea from, what you're seeing in terms of, the curves and also, true advances or non-advances in therapy.
Well, let me take just a few minutes, Buck, and I'm going to try and stay on the light side for numeric data and such, but there's a few things that we have to do to just sort of level set the discussion, I think. One is what is the virus that we're dealing with? So this has an official name of SARS-CoV-2. It has about 80% of what they call homology or similarity to the original SARS virus, which had a much higher mortality rate, probably around 10%. We call that classic SARS. And this family of viruses, the coronaviruses, for the most part, we know them through the common cold. There's probably at least 4 strains of coronavirus that produce the common cold. They're large envelope, single-stranded RNA viruses. This thing is extremely contagious. We use a scale for infectivity called the R0 scale. And if you take a virus like measles, which probably has about an R0 of 11 or 12, which means that for one person infected, maybe 11 or 12 people will actually come down with the virus from that one contact. This might be as high as 6. I mean, official estimates have put it around 3, but that's primarily using the number of known cases. And so a known case is a case that has been shown to be positive by a technique called polymerase chain reaction. In this case, reverse transcriptase polymerase chain reaction. So if you look at those numbers worldwide, we're about 2.6 million, with a mortality of about 183,000 and a case fatality rate of about 7%. Now, the problem with that case fatality rate is, again, it's only measuring those people that actually tested positive by this basic test, the PCR, which amplifies little pieces of the virus. It's looking more and more like there's a very large percentage of the population who actually have been exposed to the virus. Their innate immune system has handled it at the level of the nasopharynx, and they've produced antibodies. And long-term antibodies are called IgG antibodies. And that rate is really unknown, but probably is at least 10 times the number of diagnosed cases, which would put our fatality rates, if you look at, that's called the infection fatality rate, that would drop that dramatically, probably under 1%. To give you an example, flu mortalities are generally around 0.1%. So as far as where we're at on the curve, it looks like the U.S. is coming close to peaking, but the U.S. is a very large country. It's got a lot of variability. There are a number of states that really aren't anywhere near peaking. For instance, in Utah, we might not peak until July, even June or July. So the virus, it's very interesting as well, and I'm sure we'll get to talking a little bit more about country variability and lockdown and how tight the lockdown is to change the numbers. But anyway, that's a little basic overview before we get into the specifics.
Yeah, and one of the things, a couple of things you pointed out, I think are really important to just for people to know. This is different in that from the first SARS virus. People might remember the first SARS virus, and it was somebody else's problem, right? It was in China. It was never something that we saw in this country. And the reason for that was that the first SARS virus was so damn deadly, right? And it also wasn't something that you had so many asymptomatic carriers with. So what the paradox of this virus is that it's not like it has a brain, but it's smarter. It's a smarter virus. It doesn't kill as much. It infects a lot more, and it kills it kills less, but the pure volume of people who are getting infected is what's creating the numbers game that's resulting in all these deaths. So that's what's making it so challenging. Paresh and Ian, either one of you have anything to add with sort of the basic outline of that?
Yeah, I would just jump in and say, if we come out of the medical knowledge and just thinking about the listeners of Wealth Formula, my thoughts are the current status is evolving and still progressing. I mean, if you really look at what we know today, it's the evidence suggests that, some areas appear to be peaking, but around the U.S., we're still seeing increasing in areas really the ones that may have been a little bit less stringent with the social distancing. One of the key issues we have, and I'm sure we'll get into this later, is what's been effective in other areas has been able to test and also then quarantine and social distance. Since we haven't had that ability here in the US, that's why we forced to the whole everybody socially distance and get away from each other. And you can see some of the issues that's causing. So yeah, my thoughts are right now it's still evolving and we're learning a lot more about exactly where it's going to land. And then I think some new information is coming out also on what it's going to look like later this year when the flu peaks again.
Yeah, I'll jump on that and just say that, I will put this out there and say, we humbly recognize that today is April 23rd, 2020, and anything that we say today in regard to the current knowledge of science and the situation could be proven ridiculously false in the future.
Yeah.
And we're all sort of navigating this in the best way that we can with the best data that we have access to, and trying to convey that data to the population. Frankly, we're trying to translate that data, and that's what one of the challenges I've found myself faced with recently is to do what we do every day as practicing physician. It's to be a translator for people. It's to take complex topics and themes and convey them in stories or analogies that make them, relatable and understandable and frankly actionable. So kind of further upon that one of the biggest themes that I find myself sort of trying to convey to people is that, in my opinion, that we're not going back to how it was anytime soon.
Yeah.
Okay. People yearn for that, and they really, really just want to have it how it was in February when nobody knew about this, but that's just not a reality. And, I've heard this description that what people want it to be is a corona blizzard. It's this big, bad thing. Everybody goes into their homes, lets it pass, and then we come outside and it's sunny and we can go about our day. But that's actually probably the wrong approach. And it should be, basically we're all in all likelihood facing kind of a corona winter. It's going to be a long, protracted process where we're just going to, attempt to buy ourselves time with this isolation, and then allow the scientific method to get us ahead on various therapies and knowledge about the virus and potentially a vaccine soon. So,
yeah, I saw a study. I know recently. I think it was yesterday. I saw a study about how many people, if all of the quarantine stuff was taken off today, how many people would actually go on a plane, and how many people would actually feel comfortable going to like a football game. And the numbers were staggering, right? It was like 80% in every category from these major things were no. And so we'll get into this later, but there's an enormous economic consequence to this that we haven't even gotten close to yet. John, I want to go to you again, because I know you've been following some of the studies. We've been talking about them a little bit, even on Wealth Formula Network. Until a month ago, hydrochloroquine or chloroquine or Plaquenil, all these are the same drug in one way or another. They're old malarial drugs, and they were kind of they've been around for 50 years. Maybe Plaquenil is used to treat lupus now. It actually showed some benefits in some studies, particularly out of France, for COVID-19 in terms of at least decreasing death, maybe decreasing the amount of time to clear the virus, et cetera. And then I think based on that, I think that became a Trump mantra, to hit Plaquenil and, the Z-Pak, the azithromycin, et cetera. But then we've had mixed studies. We've had, really confusing stuff out there, and some studies actually showing increases in mortality in patients that were given Plaquenil. John, can you give us, specifically and more generally about what do we really know about the hydrochloroquine and Z-Pak without the political sauce on it, and also, if there are any other drugs that really are showing some promise?
Sure. So this really is a way, Buck, that I'm just amazing how science can get interpreted in ways that really can be extremely detrimental. I think to understand hydroxychloroquine, you have to understand a couple of other things. One is its relationship to zinc and what zinc does, and also where in the disease process you really place the drug.
Mm-hmm.
So hydroxychloroquine. So let's just talk about the progression of the disease. In my mind, it kind of boils down into 3 stages. In first week, generally you become symptomatic at right around the 5 to 6 day point. That can be out to 14 days after exposure, especially in older people. Seems to take longer for the virus to build up, but essentially, and pre-symptomatic people can be infectious for probably at least a couple of days, which further complicates. We'll be talking later about social distancing and looking actually at contact tracing and such. But essentially, you have a first week in which viral replication is going crazy. Your body's throwing a little bit of nonspecific IgM antibodies at it in that first week, but it doesn't really work that well. By day 10, you pretty much have started to build IgG antibodies to epitopes or locations inside the virus that can be attached by antibody. So that viral increase in load really is occurring in that first week and a half. Once you move into the second week, you either stabilize, the IgG works reasonably well, your viral loads start to decline, and you can still be very sick for a number of days, but you don't start entering the respiratory distress stages where you drop your saturations and you start to be real tachypnic, where you taking a lot of breaths. That's the stage where you need to be probably in the hospital watched very carefully, because you can move to ARDS and respiratory support very, very quickly within less than a day. And then there's that third stage, which is really characterized by cytokine storm, which is a bunch of proteins in your body, especially one protein, interleukin 6, which kind of goes crazy and reacts dramatically to virus being in your lower lungs. So I really feel that hydroxychloroquine doesn't do much in those later stages. Right. Hydroxychloroquine is really a drug you want to use day 1 through 5, day 1 through 7 maybe. And most of the studies have concentrated on hospitalized patients. So hydroxychloroquine is less toxic than chloroquine. What it seems to do is it increases the pH, and so it interferes with things like viral fusion to the cell and the membranes. Most antivirals work best given very early. And the other thing that hydroxychloroquine does is it helps transport, it's called an ionophore, it helps transport zinc from the circulation into the cell, and zinc really has a toxic effect on viruses. Most of the studies to date have been pretty late, have not necessarily included zinc or zinc levels. We know that people most at risk for this disease are the elderly and diabetics and obese. They tend to be zinc deficient. There have been a few small studies, and there have been a number of just empiric announcements of what clinical practice has yielded. The French study you alluded to, Buck, showed significant reduction in progression to the more severe stages. There was an early, actually, this had a control group, the Chen study in Wuhan, 31 patients in each group, and they found that fever, cough, and pneumonia improved in 81% of the treated group. And these people were treated with 200 milligrams BID of hydroxychloroquine for 5 days, no zinc added. Not much in the way of studies on azithromycin. Many people are using hydroxychloroquine in addition to azithromycin. Right now, because of the potential risk of adding multiple QT prolongers, that's the heart interval that's been discussed quite a bit. I'm not sure I would use azithro in combination, but I sure would use hydroxychloroquine and zinc early on.
So
a few other little data. Go ahead, Bob.
Just to interrupt you, I mean,
Yeah.
I mean, for the non-physicians, basically, I think what John is getting at is that there's studies out there and they're conflicting and they're confusing, and part of it simply could be that we tend to look at drugs in a vacuum, right? This works, this doesn't work. But what John is saying is, hey, this disease has different phases to it, and you have one phase that's sort of the beginning, and then the middle, and then the end. And the studies that, if I'm hearing you right, John, the studies that they're all anecdotal. They're not double, the gold standard type of testing that we want to do. But the studies out of France that were showing some promise, they were showing that if you used it early on in disease, I mean, this thing seemed to, really potentially have some benefit. And the stuff where you saw mortality, in other words, people dying more because of it, actually may have been because in people who were already in a later stage of disease. Is that what you're saying?
Yeah, there was one study that just came out that really got in the news and was just extremely irritating. This is the VA study with 368 vets retrospectively. And basically, there was a selection bias where they gave hydroxychloroquine. They kind of threw the kitchen sink at these patients who were on ventilators and in the process of dying. And then they came up and said that, yeah, more people on hydroxychloroquine died. And that got in the mainstream news and was amplified without giving the details about the fact that they gave hydroxychloroquine to people that were worse.
Yeah.
So, there's this kind of thing, and it was at a very late stage. It was basically in that what I would call phase 3 of disease progression, and you wouldn't expect hydroxychloroquine to work. It's the thing that kills you is primarily sort of a coagulation problem in conjunction with an ARDS.
Yeah, so it's your own immune system
immune system.
Yeah,
right.
that mounts a big reaction, and it's ultimately what kills you. And what you're trying to do is prevent that stage, right?
Correct.
So Paresh and Ian, jump in here. Any additional thoughts on what John is talking about, or maybe just some specific thoughts on your own feeling about, hydrochloroquine at this point? What I hate, I got to tell you one thing. What I hate seeing this thing getting politicized. I would say that, Trump probably shouldn't be, he shouldn't be, acting like the public health director of the United States. He really shouldn't be doing that. But on the other hand, the problem is that there's so much partisan stuff about this that there's a real potential that, this drug actually could be of benefit to people. And instead of looking at it objectively, it has become a partisan issue, which is just insane. So what do you think, Paresh? Ian?
Yeah, I'll just jump in and say, John summarized that very nicely, and I couldn't agree with you more. I think there's definitely seems to be some potential benefit in the early stages of using hydroxychloroquine or some derivative of that. A good analogy is in the real estate world, as we all know, and with alternative assets, everybody says, put a team together, let's figure it out and put the best people on the team. If you look at what came out of the NIH, I think in the last 24 hours is they did exactly that and said, hey, is there a benefit between hydroxychloroquine and azithromycin in people who have COVID-19 infection? That included 50 different individuals, including doctors, pharmacists, the CDC, FDA. And basically they just came out and said at the end of it that based on what they know today, at least, that they would not recommend doing that. They actually say that, the quote is they would not recommend using this with COVID-19 patients until more definitive clinical trials are needed to really get the optimal outcome. So I think that says enough. Now, is that enough to say that this will never be used or that we may not use it eventually, maybe for early stages? No, but I do think it's helpful to have that full team of experts together and give us those results.
How about you, Ian?
Yeah, no, I I appreciate those comments, and these two colleagues here joining me are, way more involved in the nuances of this than I am, and I appreciate the context that they offer. I mean, my approach to this tends to be sort of higher level. I'm certainly not a virologist, epidemiologist. I know enough to be dangerous, and I know sort of the processes that need to occur for drugs to get to market, for therapies to be effective, for the standards that we need to abide by to keep our population safe and to treat them. And in my opinion, repurposing existing therapies is probably the fastest way to sort of manipulate the curve right now, and to buy ourselves time to get additional information about how this is evolving, and to buy ourselves time to redirect and repurpose manufacturing to get personal protective gear to our frontliners and so forth. So, and I know that there's other therapies that are looking to be repurposed. I mean, a lot of talk about antibody therapy, which seems to be promising, but that's also challenged by time and resource intensive processes. And, there's a number of different drugs that are sort of being analyzed by artificial intelligence for their, for the prospects of them being fruitful. But ultimately it's going to take some time, right? Yeah. It's going to take some time for these to evolve. And I place my trust in the institutions that are performing that kind of research. And I know, and I also like to tell people this, that there's been really no point in recent history where the entire world's scientific community is pulling the sled in the same direction. Like, there's some smart people working on this. Everybody's kind of working on this, and ultimately we're gonna figure something out that's gonna prove.
Yeah,
it will take some time.
Can I just make a quick comment?
Yeah,
Buck?
absolutely.
I just, one thing that is a little frustrating is for experts, and I'm not a virologist or an epidemiologist either, but to say there's no data that anything really makes a difference, and that we need to wait for phase 3 clinical trials. Well, those will occur. They'll be available probably in 6 months, but it also is, those people in New York are in the trenches. There's, at one point, thousands of people dying every day, and it is the art of medicine. And I guess, and I'd like to get an opinion from all my colleagues on the show, whether they would use hydroxychloroquine if they developed a fever to 101, shortness of breath, and cough.
I think
and when they would do that.
That's a great question. Yeah.
I think we have to get that question answered. But one thing is, there is a point where you look and you just say, okay, clinically, what's the risk-benefit ratio of intervening? We give hydroxychloroquine to thousands of people going on trips as an anti-malarial.
Yep.
And to me, the risk-benefit equation of doing this is well within the bounds that I would be comfortable with.
I would just echo something there, and I think that from what I've seen from the literature, and I haven't dove as deep as John, but I've been trying to read the more significant studies. But for me, anecdotally, and again, this is not medical advice at all, and just because, when I think about the studies that most reflect somebody who's an early disease, and who, doesn't have an underlying heart problem, which, I don't think I do. If I had a strong suspicion of, that I was infected, I would probably opt to take the Plaquenil hydrochloroquine. And again, it's because I don't think the data is clear, but I think that, the French studies out there they're not perfect, but there's more better than, a little bit of evidence there. I think, so I would do it. Paresh, I'm guessing you're a no on that one.
No, it's not a zero-sum game at all.
Yeah.
And if the evidence was there and suggestive that I had exposure, or it seemed like it was higher than average chance that I contracted the COVID-19 infection, definitely would be on my list. I'm definitely not a hard no.
Yeah.
I think we run into this issue all the time in medicine, and this is just one that happens to get international spotlight, rightfully so, is what do you do boots on the ground, and what do you do with what a clinical trial says?
Yeah.
And sometimes it's a very difficult decision.
How about you, Ian? Would you do it?
I think it's situational dependent. Yeah. I mean, I don't have a strong opinion yet. I would probably lean towards considering it based on what we see and based on, and this is just coming from where I am health-wise. I don't have a known heart problem. I'm fairly healthy, and I would like to, be in the cohort that survives this. And that seems to be a low risk way to maybe add an incremental benefit.
Right. There is one little other data point, Buck. Costa Rica has 681 cases. So you heard, we're internationally around 5 to 7% on our case fatality rate, which remember is only the clearly diagnosed cases. Costa Rica started using this hydroxychloroquine regimen very early in their curve. And their case fatality rate, not infection fatality rate, is still below 1%. They've had 6 deaths doing that. So, kind of indirect population data, but still interesting.
One other question I have for any of you is obviously, Plaquenil is used for patients with lupus. So are we seeing people with lupus dying? Do we know? I mean, if there's a lower incidence of infection, I mean, obviously lupus is not something that you probably can get a huge amount of data in a short period of time, but has anybody heard about that?
Jump in right afterwards, but the lupus spectrum is wide, and the degree of patients that are using frontline or mild to moderate level treatment like hydroxychloroquine versus some of the other patients who are using more significant immunosuppressants. It's kind of hard to tell. I have not seen anything, but I have not been on that look for it either.
Got it. John?
I just have an anecdotal report of one patient who was on 200 milligrams of Plaquenil a day for discoid lupus. She was hospitalized with worsening COVID-2. We, in discussion, talked to her hospitalist, increased her dose from 200 to 600 and added azithromycin. And the next day, she started to reverse her oxygen needs and drop from 4 liters down to 1 in about 24 hours. But, again, a single anecdotal case, not sure what to make of that.
How about is there any other drugs that I think, just briefly, I mean, obviously we can, we've got some other things I want to talk about, but any other really promising drugs here that anybody knows about?
I think the IL-6 story is very interesting, Buck. So that's interleukin 6. It's probably the lead cytokine or little tiny protein that gets excited in cytokine storm. There's 2 drugs undergoing trial right now, tocilizumab and sarilumab, Kevzara. And they're both very interesting. There's a German study that showed that if your IL-6 level got higher than 80 picograms per ml, you were 22 times more likely to need a ventilator. So, that's something that all the critical care docs are following now in the ICU. And these 2 drugs are potent inhibitors of IL-6. So we have a little bit of preliminary data that suggests that it works in more severe cases. But big studies are these drugs really need these major phase 3 trials, and they're ongoing. They started in the beginning of April. The only other drug that I would want to say something about is remdesivir. This morning they accidentally released the results of their early Chinese study, which looks like it didn't help all that much. It is a drug that binds to viral RNA polymerase.
That's the Ebola drug that was designed for
the Ebola drug that didn't work, but worked fairly well in SARS and MERS. So I don't know. We'll have to wait and see what the American studies on that look like. But again, it's a drug that mainly impacts the virus. And if you're talking about late stage people, it's a good question whether impacting the virus is going to matter at that point.
So that's it for part one of this series on COVID-19 with these three doctors, me making number 4. I hope you enjoyed that. Now, next episode, what we're going to do is we're going to change our focus a little bit. We're going to focus going from the disease and potential treatments to the ideas behind vaccines, what some of the limitations are there. And then finally, of course, we are going to talk about some of the economic impact of the virus. And so don't miss that. That's it for this episode of Wealth Formula Podcast. This is Buck Joffrey signing off.
Thank you for listening to the Wealth Formula Podcast. Visit us on the web at wealthformula.com. The information contained in this podcast are opinions, not fact. As always, consult your own financial team before making any investment. See you next time.